Okay, now we'll do urinary tract neoplasms. Mm-mm-mm. Urinary tract neoplasms, epidemiology, it's more prominent in men than female. There are two types: transitional cell carcinoma, squamous cell carcinoma. Transitional cell carcinoma is greater in white individuals. Squamous cell carcinoma is common in African Americans. 60 to 70 years is mainly is peak incidence, and transitional cell carcinoma is most common 95% of the time, and squamous cell carcinoma is 60%. Adenocarcinoma is the rarest type and it's less than 5% prominence. Okay. Risk factors of urinary tract neoplasm is transitional. Okay, there are different risk factors for different types of urinary tract neoplasms. So, for transitional cell urothelial carcinoma, the risk factor is tobacco, aromatic amines, smoking, cyclophosphamide, phenectin, heavy metals like chlorine and arsenic, pelvic irradiation, augmentation, cystoplasty, kidney tumors. Okay, pelvic irradiation, augmentation, cystoplasty, and kidney, not tumors, transplant, kidney transplant. Okay, then you have squamous cell carcinoma, which is also because of tobacco or smoking. So, schistosomiasis as chronic inflammation is a bacteria or something, I'm not quite sure. Chronic recurrent UTI, chronic nephrolithiasis, and bladder calculi. Adenocarcinoma is a medical history of Urcus remnant, cystitis cystica, and bladder extrophy. So over here we can just say chronic nephrolithiasis. This one is important. And tobacco, chronic inflammation basically is for squamous cell carcinoma. Clinical manifestation for urothelial neoplasms is hematuria, dysuria, that you can't produce urine, and then urinary retention and hydronephrosis. Okay. Metastatic disease is enlarged lymph nodes, liver, lungs, and bone. Liver, lungs, bone is what a kidney metastasis from the kidney will affect liver, lungs, and bone. Liver will cause hepatomegaly, jaundice, ascites. Lungs will have dyspnea, cough, and chest pain. Bone will have bone pain and wrong pain in the, especially the vertebrae is very troublesome in the vertebrae. Now, staging. Tx is the primary tumor, cannot be assessed. T0, there is no evidence of primary tumor. TA means non-invasive papillary carcinoma. Non-invasive papillary carcinoma. TIS is carcinoma in situ, which is a flat tumor. T1 is tumor invades the subepithelial connective tissue. T2 is tumor invades the muscularis propria. T2A is tumor invades the superficial muscularis propria, inner half. T2B is the tumor invades the deep muscularis propria, and T3 is tumor invades the perivascular tissue. Okay, T3A is microscopically, and T3B is extravascular mass. Okay, this is not that important, but just remember perivascular tissue is invaded in T3. Now T4, the tumor invades the prostatic stroma, seminal vesicle, uterus and vagina. T4A, pelvic wall and abdominal wall, and T4B is pelvic wall, abdominal wall, and prostatic stroma, uterus and vagina. Okay. NX is lymph nodes cannot be assessed, and NO means no lymph node metastasis. How do you grade it? Grading is based on urothelial papilloma is grade 1. Urothelial neoplasms of low malignancy, okay. Papillary urothelial carcinoma low grade, papillary urothelial carcinoma high grade, carcinoma in situ, and invasive urothelial carcinoma. These are the different grades. You have Urothelial papilloma, urothelial neoplasm of low malignant neoplasia, papillary urothelial cancer carcinoma, low grade, papillary urothelial carcinoma, high grade, carcinoma in situ, and invasive urothelial carcinoma. Okay, diagnosis. First is urine analysis with microscopy. Desmograph if it has RBC or RBC casts, proteinuria, a glomerular cause, blood test, CBC, CMP, imaging, CT urography, MR urography, and renal bladder, MRI with contrast and ultrasound, urine cytology and biopsy. Treatment is non-invasive papillary carcinoma and early PET1, invasive lesions, transurothelial endoscopic resection, intravesicular immunotherapy, chemotherapy. Okay. Radical resection, cystectomy, and pelvic lymphadenectomy. Metastatic spread after treatment is frequent. Metastatic spread after treatment is frequent. Pathogenesis. So, there is bladder epithelium. If there is deletion of a tumor suppressor gene on chromosome 9 short arm and chromosome 9 Q arm, long arm, then it causes papillary tumor, okay, which is a precursor lesion. If there is further mutation in the p53 gene, then it causes invasive urothelial carcinoma. Now, on the other hand, if you have mutation of p53 before, so you have mutation in p53, it directly causes carcinoma in situ, which is a precursor lesion for invasive urothelial carcinoma. And then if you have deletion of short arm of P or the short arm of chromosome 9 and long arm of chromosome 9, it causes invasive urothelial carcinoma. And there are types of urothelial cancer. One is urothelial carcinoma, squamous cell carcinoma, and adenocarcinoma. So morphology of non-invasive papillary tumors. Okay, you have morphology of non-invasive papillary tumors. What does it look like? The common precursor lesion to invasive urothelial carcinoma. So this one, non-invasive papillary, is a precursor lesion. To invasive urothelial carcinoma. Then stable for years before invading the subepithelial connective tissue, cauliflower-like polyps. It is removed by endoscope. Mucosa is elevated, forming papillae covered with thickened urothelium. The urothelium is thickened and can have low-grade or high-grade dysplasia. Pathologists look for invasion. High-grade dysplasia is a serious risk. High-grade dysplasia is a serious risk for invasive cancer. And urinary cytology, the cells of urothelial papillocarcinoma. Urinary cytology will show cells of urothelial papillocarcinoma and cannot be distinguished from inflamed or non-neoplastic urothelium. So in urinary cytology, if you see cells of urothelial papillocarcinoma, you can't distinguish if it is from a cancer or an inflamed one. Prognostic factor depends on the grading of the tumor. Then you have urothelial carcinoma in situ, the precursor lesion with high grade dysplasia. It's a precursor lesion which has high grade dysplasia, high risk for progression into invasive carcinoma. Okay, it is not visible well in cytology. Okay, well, cell cytology you can't find it. Urothelium is replaced by the entire thickness by highly atypical multi-layered columnar cells. Okay, urothelium is replaced by entire thickness. Urothelium replaced by entire thickness by highly atypical multi-layered columnar cells. Atypical cells also shed into the urine, making cytology detection possible. It has a flat epithelium. This one had a cauliflower-like polyp, which was removed by an endoscope. Okay, invasive urothelial carcinoma. Invasive urothelial carcinoma can either be invasive papillary carcinoma or invasive flat carcinoma. Invasive urothelial carcinoma is a high-grade epithelial tumor develops from urothelial papillocarcinoma or carcinoma in situ. These are the two precursor lesions. The strands and groups of atypical epithelial cells infiltrating into the subepithelial mucosal tissue or within the detrusor muscle. Cancer cells have urothelial differentiation and they are positive for P63, GATA3, and CK5 and 6. Focal squamous and glandular differentiation is possible. Invasion into the lymph vessels is frequent. Papilloma is benign. There is no malignancy, very rare, covered by bland urothelium without ATP. That is it, I guess. Invasive urothelial carcinoma. Okay. Urothelial carcinoma. These are precursor lesions. Okay. Morphology of non-invasive papillary carcinoma. Papillary tumor. This one is non-invasive. This is non-invasive, and this is carcinoma in situ. Invasive urothelial carcinoma and non-invasive. Okay. Carcinoma. Yes. This is what they're talking about in the first one. This is the second one, and this is the third one, I think. Let me check. Yeah, and the fourth one is a papilloma, which is benign. The first three were malignant. Okay.